Hello, I'm Fiona Ritchie.
And I'm Nik Kendrew.
We're both part of the Redwell team.
Come with us to reignite your passion for primary care.
Welcome to the It's Friday the 13th, What's Going to Happen? Primary Care Pod from Redwell. The Primary Care Pod from Redwell.
So grab your preferred drink of choice or your trainers, clutch your pearls, shake your jingle bells. And let's start with the headlines. Here's what's coming up this week. I get completely covered in an itchy rash. Not me, I should say, it's the patient. Could it be chronic urticaria? This is one of those conditions where a good photo at the time of the attack can make the diagnosis easier. How confident are you in spotting and managing it?
And preparing for the worst. End-of-life care can be one of the most rewarding parts of our jobs, but it can also be one of the most stressful. We consider the important issue of bleeding and haemorrhage in advanced cancer.
And here's what's coming up next week. Diagnosing diabetes. Do you know Modi from Larder? It's recently been World Diabetes Day, and we wanted to support this by sharing some Redwell diabetes content.
PSA testing in asymptomatic men. This emotive subject has been in the news and social media over the past few weeks, and there will have been many requests for PSA testing. So, listen next time to find out more.
Now, you may have noticed that we've got a new voice on the podcast this month, so it's a big warm welcome to Fiona, and we're going to introduce her properly to you in a few minutes. But first of all, we have to get her to earn her keep. So we're going to start with the first pearl of the month. Now, this one is chronic urticaria, and it took me 8 minutes and 42 seconds to read. So a nice short one to start with. Fiona, what did this one mean for you?
Well, Nick, this was the one that made me itching for more. Sorry, you won't be asking me back. No, but seriously, urticaria I'm comfortable with, but I wasn't so sure on the chronic aspect of it and how that changes our diagnosis and management.
Absolutely. So why are we talking about this? Well, there's two things. Firstly, it's pretty common, affecting 0.5 to 1% of adults at any given time. And as the DTB review in 2021 states, it can be tricky to manage. And secondly, it really affects quality of life. Now, a 2022 NEJM review points out that the quality of life reduction in chronic urticaria is similar to that seen in patients waiting for a CABG.
Yeah, that was a bit of a mic drop for me. I couldn't quite believe it. So it's one that we really want to pick up and manage well. And of course, the full written pearl is based on those reviews by the New England Journal of Medicine and the Drugs and Therapeutics Bulletin. And what we're going to do today is to pick up the headlines that you need to know right now before you read the free pearl, which of course you can find on Redwell Knowledge or via the links in the show notes. So firstly, is it or isn't it chronic urticaria? Chronic urticaria tends to have a similar clinical presentation as the other types. So it's that transient, intermittent, red, raised, itchy skin eruptions, ranging from, well, anywhere from a few millimetres to several centimetres in diameter. And of course, for it to be chronic, it needs to last for more than 6 weeks. But on our differential list, and in the much more serious department, is vasculitis and angioedema.
So how do we differentiate from those?
Yeah, it's a good question. So if we have lesions that do not resolve within 24 hours without bruising or pain, that's the important bit, then we need to be considering vasculitis and referring on appropriately for that. In urticaria, the changes are occurring at a superficial level in the epidermis, but in some cases it may be associated with angioedema, where a similar process occurs, but now in the deeper dermis, and this is much more severe, potentially even affecting swallowing and breathing. Angioedema may also affect the genitals and the GI tract, and this is a situation where we need to pick up the phone and speak to dermatology immediately. So Nick, can you tell us about how we would go about diagnosing it?
Sure. So chronic urticaria is further defined by whether a trigger can be identified or not. If no trigger is found, then this would be our common chronic spontaneous urticaria or chronic urticaria associated with a systemic illness. So think about things like rheumatological disease, hematological malignancy, also infections such as hepatitis B and C, and also TB. Now, this is rare, but it's important to have an awareness of it so we can link it all up and get them referred on quickly. Now, there are lots of examples of types of chronic urticaria where a trigger is identified. Most are termed physical or inducible urticarias, and these may sound fairly logical to you, and they are things like heat, cold, pressure, and this is seen either immediately as dermatographia or as delayed pressure urticaria, for example, from a belt or from a bra. Other things which would be inducible would be from vibration, sunlight, stress, menstruation, and exercise. And no diagnostic sieve would be complete without the drugs category. So we're talking here about non-steroidal anti-inflammatories, opiates, ACE inhibitors, and alcohol can also be associated.
Thank you for that, Nick. That's really helpful regarding the classification of the triggers there. A learning point for me, and it's quite a serious one as well, is that people with exercise-induced urticaria are at risk of exercise-induced anaphylaxis, which was quite a shock to read, actually. So definitely one to be aware of and definitely one to keep in the grey matter there.
Absolutely. I wasn't aware of that either. So from our seemingly run-of-the-mill chronic urticaria, we've ended up with shocking quality of life impact, vasculitis, angioedema, and potentially anaphylaxis.
Yeah, and of course, what we really need to say here is that we're not trying to cause anxiety to anyone, but yes, of course, we think it's really helpful to know these potential risks, and that's simply so we can care for our patients even better.
Yes. And of course, you know, in the process of that, we'll be doing a diagnostic workup. So thinking about the investigations for that, the DTB article recommends very simple blood tests. So full blood count to look for underlying infection, also hematological malignancy or eosinophilia suggesting parasites. They also recommend an ESR or CRP to look for underlying infection or inflammatory disorder. Interestingly, the NEJM review states that we don't need to screen for potential underlying infectious causes in an otherwise healthy person, as these are very rare.
Oh, that is interesting. Slightly different there. Okay, well, otherwise that sounds actually quite straightforward, so we'll welcome that. But what about management, Nick?
So the general advice, as you would expect for all, and these might be enough for those with mild symptoms, are avoiding exacerbating factors such as overheating and tight clothes, also avoiding triggers, for example, NSAIDs and alcohol. Now, in terms of active management, here's another learning point. The NEJM review advises that antihistamines should be taken regularly in chronic urticaria to prevent flares, rather than on an as-needed basis in response to them.
Okay, so which ones are we talking specifically?
Well, we're advised to use standard dose, non-sedating, long-acting, second-generation antihistamines as the first-line choice if medication is needed. Now, unfortunately, there are no head-to-head trials comparing different drugs, so we can't say which is most effective. But what we can say is that we should choose the cheapest over-the-counter preparation first, something like cetirizine or loratadine. Now, there are alternative options too, so have a look at the handy table in the Pearl for those. Now, if one drug is ineffective at the standard dose, it's worth trying an alternative as response varies.
Yes, and another little pearl of information here. You might be thinking, okay, well, what about first-generation antihistamines? For example, chlorphenamine and promethazine. Well, these are not recommended first line. And why is that? Well, it's because they only have an antipruritic effect for 4 to 6 hours, so not really that helpful in this case. And their sedative effect lasts at least 12 hours. So for us in this situation, it's not the best risk versus benefit profile seen. So that's which antihistamine, but the Pearl also highlights at what dose.
Yes, that's right. A Cochrane review from 2014 showed only modest benefits of standard dose antihistamines for some patients. Some didn't respond at all. And that's why high dose antihistamines have their part to play in management. Now, when we're talking about second line options, then several national guidelines, including those from the British Association of Dermatologists in 2022 and the British Society for Allergy and Clinical Immunology in 2015, recommend that higher than licensed dose of second generation antihistamines such as loratadine or cetirizine may be used if symptoms have not responded adequately to a trial of a standard dose of at least 2 second-generation antihistamines.
So higher than licensed doses, well, what does that actually mean for us? They recommended doses of up to 4 times the standard dose in both adults and children. So what's the evidence available here? A number of small but imperfect randomised control trials have shown that these higher doses can be effective where lower doses have failed and appear to be safe and well tolerated, but they are not effective for everyone. A systematic review of 15 studies, 5 of which were high quality, compared standard and very high dose regimens. It found no difference in the number of wheals, but a greater improvements in itch in the higher dose group, which might be important to some of our patients, of course. Of that group not responding to standard dose antihistamines, 60% did respond to those higher dose antihistamines. Now, it's really important to say here that prescribing second generation antihistamines at these doses is off licence and should be discussed with patients as per GMC guidance.
Yes, and also documented in the notes so that it's all there to show that you did it.
Exactly.
You'll see in the Pearl that there are some other options such as leukotriene receptor antagonists like montelukast, but we'd suggest seeking dermatology advice if considering those. And secondary care may also think about steroids and monoclonal antibodies, but that's not something for our consulting room. If you're interested though, have a read of the evidence base in the Pearl. Now finally on this, NICE recommends referral to dermatology or immunology if symptoms are not adequately managed with antihistamines or if there is diagnostic doubt. So what about the prognosis with this, Fee?
So spontaneous remission is the most common outcome, which is great, but 10% will still be affected after 5 years. So we need to remember that and the effects, of course, of any chronic disease on both physical and mental health. Prolonged symptoms are more common in that physical inducible urticaria group, Nick, the one that you were talking about. Mm-hmm. So for those with an identifiable trigger such as heat or pressure. And of course, we need to recognise that relapses also occur. So urticaria can be quite unpredictable. And this is where our great communication and safety netting is our friend here. So here are our learning points for chronic urticaria.
Recognise it and rule out the more serious differentials.
Use second-generation antihistamines at standard dose or higher doses as required, noting that this is off-licence.
If antihistamines are not working, then refer to secondary care where a range of treatments are available. So that's the first Pearl of the month done, and a very warm welcome to Fiona. Hi Fee, how are you doing? Some applause for you.
Ooh, thank you. Gosh, I'm so lucky. Thanks, Nick. I'm really well, thank you. I'm delighted to be here.
Well, you're very welcome.
My festive bells.
Absolutely. We had Ali last month and Ali's back next month, so it's going to be sort of widening the team, isn't it, really?
Yeah, exactly. It's it's just nice to be in the fold.
Yes. So I wonder if you could maybe introduce yourself for everyone.
Yeah, I'd love to. So hello, everyone. My name is Fiona and I'm a GP in Hampshire. I've been working with Redwell for about 5 years now, and I absolutely love it. I've probably met some of you either across the digital waves on courses or face-to-face. And alongside presenting those courses and writing teaching material, I've been working on the podcast in the wings. So I'm delighted that they finally allowed me to come on an episode. Ta-da! So maybe, Nick, you could have a poll to see if I can come back again. Is that something you can do from the listeners?
I'm sure. We don't need to do a poll. It's all fine.
We love feedback at Redwell, so any feedback, we just love that.
And do the jingle bells come every time that you're on the podcast, or is that just a festive thing?
I think we could negotiate that. Or maybe not jingle bells every time because they are quite festive, but we could have some sort of additional musical prop, maybe. The
reason that I ask about the jingle bells is because this isn't the first podcast that we've done together, is it?
No, it's not. It's not. So a few years ago, and I remember it so fondly because it was September and it was beautifully warm and sunny, which is not the weather right now. So we did a couple of episodes of Boggle Docs together, didn't we? And we managed to find some primary care CPD around Christmas things. So we watched the film Last Christmas, and perhaps most impressively, we because we have a shared love of it, The Muppet Christmas Carol.
And the jingle bells were on those as well, you see. And do you know that finding the learning in the Muppet Christmas Carol and putting it in my appraisal is one of the things I consider a career high. Now, the episodes, if you want to listen to them, they are still live. If you want to go back.
Are they?
Yeah, they're still on there. Especially if you haven't got the bandwidth at the moment for formal CPD, then I've coined the term i-CPD, which is I being for incidental CPD. So go and have a listen, treat yourself, have a laugh, and you might learn something. So there we go. Right then. On to some more formal learning now. And so the second pearl of the month, and this one is an emotive topic, and it's bleeding and haemorrhage in advanced cancer. Now, it might be that you're not in a place to be able to think about this at the moment. And if that's the case, that's absolutely fine. And so if you just want to forward the podcast by 7.5 minutes, then we'll have been to the end of the teach on this one. Now, this one took me 4 minutes and 42 seconds to read. So an espresso shot of learning. So really useful learning as well. And something that I'd wish that I had available to me to read when I first started out as a GP. What about you, Fee?
Yeah, this is the one that made me think, mainly because I'm not sure I've ever been involved in someone's care where this was an issue. And as we'll discuss, it's one of those situations where we'll be getting palliative care involved, if not already, and they may take the lead. But it's really important that we as primary care clinicians are abreast of the plans and are a source of support for the patient and their families. So essentially, this is about preparation, preparing for the worst, but of course, hoping for the best.
Exactly. So why are we talking about this? Well, significant bleeding is common. It may occur in 10 to 20% of people with advanced cancer. Catastrophic terminal hemorrhage is rarer, but of course is a very important palliative care emergency. Now, the written pearl is based on the Scottish Palliative Care Guidelines, Bleeding, accessed from November 2023, and I'll put a link to those in the show notes. So, as Fee said, we should consider whether a significant bleed may be anticipated. Now, this might be where a tumour has infiltrated a major blood vessel. Very large tumours, for example, lung tumours, primary or metastatic, those that are more than 10 centimetres have a high risk of bleeding, and palliative radiotherapy may be offered to reduce this risk. Head and neck tumours, now, if they're close to the carotid artery, they may well, understandably, cause a bleed. Thrombocytopenia or abnormal LFTs with abnormal clotting would be another situation where you'd be thinking about bleeding as a possibility. And the appearance of pulsatile swellings should also ring alarm bells. Smaller warning bleeds should also get us thinking along these lines. If these occur in the community, then we should discuss with the specialist palliative care team or the oncologists, because palliative radiotherapy or interventional radiology techniques may be beneficial and reduce the risk of a catastrophic terminal event. Are there any practical tips to help with these small warning bleeds, Fee?
Yeah, there are. So it's important to say that unless you already have expertise, we would recommend that you ask for specialist advice about these treatments. If you have a patient at risk or starting to have small bleeds, then consider discussing anticipatory prescribing of these or similar options with your specialist team and district nurses. For bleeding and fungating wounds, they might offer gauze that's soaked in tranexamic acid or adrenaline, or hemostatic alginate can also be used. If there's bleeds from the mouth, then they may also respond to tranexamic acid or socralfate mouthwashes. If there's gastrointestinal or genitourinary tract bleeding, then that may respond to oral tranexamic acid or socralfate.
So, Fee, now you know a bit more about this. Do you think it's something that you'd feel comfortable discussing with a patient and their family?
No. In short, I think it's something that would make me want to run a mile, but I appreciate it's something that really is important. So we've got to kind of work that one out. How about you?
Exactly. Yeah, I mean, having read this as well, I mean, I feel much better having read it, but it's a very difficult conversation, a very difficult situation, isn't it?
Yeah. And Nick, I don't think we're alone here. And for everyone who's listening, I think you're probably, thinking along the same lines. Of course, our utmost priority is looking after our patient and their family. And so we want to handle this well. Now, of course, this kind of issue causes a huge amount of anxiety for all involved, including us. And so it could be very easy to take that anxiety into the discussions and actually make things worse, maybe not even by realising it. So we would suggest treading really carefully here.
That's right. And we recommend that you initially discuss with colleagues and potentially the community specialist palliative care team before deciding whether to have a conversation with the family and or the patient. This is a difficult tightrope to walk, and there is potential for this to go wrong. Discussion with patients and relatives may cause unnecessary anxiety and concern, and there should be careful assessment of how beneficial this may be for a particular individual.
Of course, we know that it is good practice, however, to offer patients and their families the opportunity to discuss any worries or concerns that they may have about the mode of death. And it may be appropriate to discuss the risk of terminal bleeding if it is raised by the patient or a family member, if knowledge about the risk allows the patient or the family to change their behaviour in a helpful manner, or of course if there have been warning bleeds. And there are special circumstances which make it valuable for the family to know, for example, if there are children in the home.
Exactly. And our gold standard palliative care rulebook still applies here. So we need to be ensuring that there is clear communication with other members of the community team and that the best place of care and death is discussed. We should be mindful that the potential for bleeding may alter previous plans and that things like capacity may need review. Sophie, what are the practical things that we can do to prepare?
Yeah, so a few helpful top tips here. So firstly, a really easy practical tip. We can suggest that dark colour towels and bedding and gloves and aprons are available to use at home, and that would be to reduce the impact of bleeding should it occur. Then on to medication. So firstly, a really good primary care skill is starting with a medication review. So it might sound really obvious, but it can be, missed sometimes in the midst of everything, but making sure that we've considered whether we want to stop antiplatelets, NSAIDs, DOACs and anticoagulants. For managing anxiety around bleeding, we can use lorazepam, and that is helpful if there are concerns about the escalation of recurrent small bleeds. It can be administered sublingually. Do have a look at the article for doses. We should also make sure that they have the just-in-case medications available to deliver in the event of a distressing bleed. Now, that would be midazolam 10 milligrams intramuscularly, which is faster than subcutaneous delivery. Obviously, this is only really going to be an option if someone is available 24/7 to administer it, for example, in a nursing home. And there are non-injectables which are available, such as PR diazepam and buccal midazolam, if not. In reality, though, most people with a catastrophic bleed will lose awareness very quickly, and medications will not have time to work before this happens.
And most importantly, in that scenario, somebody needs to stay with the patient because nobody should die alone in this way. As always, we should also offer support to staff and the family after death and seek support for ourselves if it's required. So here are our learning points for terminal bleeding. Think about it.
Talk about it with your colleagues first.
And prepare for it. You've got the calendar there, haven't you?
I do, yes. Well, of course, we are looking forward to January. It's 2025. Lots of exciting things on the horizon in the new year. So firstly, you won't necessarily know this, but in the Red Whale world, we get together, we have an annual get together for our own training, and we have that in January. So it's always actually quite a nice highlight, isn't it, to have something fun to look forward to in January, especially after the festivities. So that's where we have a big authoring meeting. We have creative workshops. You'll also find a few people bopping away to the silent disco. So it's our real kind of reset, isn't it, Nick, in January? Yeah. And we go big on thinking about how we can learn the best with you lovely people in 2025. So that's happening. And then on the calendar, we've got some exciting things coming up. So Hussein is hosting a lifestyle course on the 17th. Some of you folk who are tuning in from Wiltshire may be joining Osman and Steve for a cancer update. There's Study Day Lives going on across the board. And Susan and I will be hosting an urgent care course digitally on the 31st. So please do come and join us if you are available.
So that's the 31st of January for the urgent care course. Sign up now and you can see Fee and Susan presenting that.
You can see my actual face.
Yes, exactly. Or, they could just listen.
And no jingle bells. Yeah, they could just listen if that's more palatable. Yeah. So also, Nick, our new trainee package has been really popular, hasn't it?
Yes, so the GP Trainee Essential Support Package. So this is exclusively available to GPST MDU members and affiliates. So if you are one of those and it's free, it's worth £165 and it's designed to build your knowledge and confidence and help you pass your exams. And so what's included, I hear you ask? Well, it's really helpful because it's got Red Whale Knowledge Access, which is over 900 written resources to support you during consultations and also with your CPD. Also, the Top AKT Topics Digital Handbook, which covers areas that trainees struggle with the most, and webinars throughout the training year to support you with your exam preparation. So if you click on to the link, then you can sign up for that.
Please note that the package is completely free for MDU affiliate and GPST members, but MDU GPST membership itself does carry a charge to sign up. Our GP Trainee Essentials package is a free benefit of affiliate and GPST MDU membership.
Okay, time now for our primary care superheroes. So Fiona, who have you got?
Well, first up we've got Josie Roberts, and this nomination comes from one of our delegates from the Women's Health course in London just last week. And Josie is a receptionist and dispenser for Lonfor Surgery in North Wales. And the nomination comes because everyone loves her. They say she's always happy. She's the happiest person ever. She's always got time for everyone, never moans about anything, and loves helping patients. So well done, Josie. And the next one is one of my nominations, actually, Nick, which I'm going to take for my first time here. So I'd love to nominate Debbie Reynolds, who's one of my colleagues. She's a nurse at North Baddesley Surgery in Hampshire. And Debbie is just being brilliant. She's just brilliant anyway, but especially at the moment, because in an attempt to get us reprobates to get infection control, Debbie has ingeniously devised a very festive elf on the shelf. Other elves are available, whereby she sends us all from the elves an infection control conundrum every morning in December, and then a poll to answer the question and really embed that learning. So Florence Nightingale,
Wow.
Eat your heart out. Well done, Debbie.
Excellent. Well, Debbie sounds like a complete superstar, so thank you for that. Hannah, GPST2 has texted in. She's listening from Aberdeen while she does her gym workouts and driving around Scotland. She says, hopefully helping my AKT preparedness for January. So good luck for January,
Good
Hannah.
luck, Hannah.
Yes. And finally, Tara has texted in. It was in reference to last month's podcasts. So she says that loving the pearls, but surely everybody knows fruit toast goes with tea and not a latte. I'm going to check the guidelines on that, Tara, and good point, well made. So it could be tea or any other drink.
It does come with a winky emoji, so I think if you objected, I think Tara might accept that.
I'm not objecting. It's all good. So thank you for all of those primary care superheroes. And as you've seen, if you are on a course, a face-to-face course, then by all means, go and give your name for the primary care superheroes, either to one of the team from Delegate Services, or also you could give it to one of the presenters as well. And one of the breaks, they'd happily pass those on to us. And if you want to text them in, then if you press the button on your preferred podcasting platform, send us a text, then that would be greatly appreciated. So thank you very much. Now, if you are hankering after a Red Whale Knowledge subscription, then we're offering a 10% discount on Red Whale Knowledge for our fabulous Red Whale pod members. So how do you become a member, I hear you ask? Well, if you are listening to us right now, then you are part of our pod, so welcome. All you have to do is go to redwhale.co.uk, put Red Whale Knowledge in your basket and enter the code RedWhalePod to get 10% off. And here's a small print. The discount is only for this product and won't work on anything else. And please also note that this voucher code is all one word and all lowercase, RedWhalePod.
If you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It only takes a few seconds of your time and we'd really appreciate it. If you can spare a little more time, then please leave us a nice review too. Because of the way the algorithms work in the podcasting world, it means that other people just like you can discover us and learn something too.
Exactly. And of course, putting algorithms to the side, there is no greater recommendation than a word of mouth recommendation. So if you've got some value from listening to the podcast today, then don't keep it a secret. Please tell everybody that you know who might also benefit from listening. All the resources that you need are in the show notes, and all the links are in the show description on your preferred podcast platform.
You can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. If you want us to see something about the podcast, then please use the hashtag RedWhalePod.
And the other thing that you can do if you click on the link in the bio is to leave us a voice message telling us about anything that you found helpful or would like us to go over.
You can also email us. Our address is podcast@red-whale.co.uk. Until next time, I'm Fiona Ritchie.
And I'm Nik Kendrew.
Remember to keep Red Whale knowledge open on your desktop at work, so we're with you when you need that bit of extra information or reassurance.
Take care and look after yourself. Bye-bye.
Goodbye.